Hello, everyone, and welcome to the InTouch Health webinar series. This is Scott Young, and I'll be your host for today's webinar. Today, we'll be featuring Dr. Bridget McCabe, Dr. Javid Siddiqui, and Joe DeVivo, and they'll be presenting on protocols and procedures using telemedicine in response to the coronavirus. Dr. McCabe is a dual board-certified physician and IT leader with cross-cutting experience in clinical research, medical affairs, big data science, pop health, and the use of advanced analytics to support the clinical consumer economic value story. She has 17 plus years of executive leadership in industry, government, and academia. Dr. McCabe has an established track record in digital and operational transformations by leading teams, mentoring talent, P&L ownership, strategic vision to action, and successful large-scale product program launch with measured results. Dr. Siddiqui co-founded Telemed2U, where he serves as the Chief Medical Officer and is the primary developer of clinical programs and strategy. He directs Telemed2U's extensive group of multi-specialty medical providers and is instrumental in managing the operational and business development aspects of the practice. Dr. Siddiqui also practices inpatient and outpatient telemedicine as an infectious disease physician member of the group. Joseph DeVivo brings a proven track record of 30 years of extensive business leadership and 25 years of medical device experience, ranging from small startups to large corporations. Prior to joining InTouch Health, he served as President, Chief Executive Officer, and Director at AngioDynamics from September 2011 through the summer of 2016. Joe also held positions as Global President of Smith & Nephew Orthopedics between 2007 to 2011, President and Chief Executive Officer and Director of Rita Medical Systems, Inc. from 2003 to 2007, President, Chief Operating Officer, and Director of Commuter Motion Incorporation from 2002 to 2003, and Vice President, General Manager at U.S. Surgical Davis, a division of Tyco International Healthcare Business from 1993 to 2002. We will begin the webinar shortly, but first, a few notices. You have all been auto-muted. If not, though, please make sure to mute yourself. During the webinar, you'll be able to enter questions in the questions widget located on your audience console. Questions will be answered throughout the presentation, so please feel free to ask your questions at any point during the webinar. If a fuller answer is needed or we run out of time, questions will be answered later via email. This webinar will be recorded, and a copy of the recording will be available on our website and sent to registrants. And this webinar presentation should last around 60 minutes. And now I'd like to turn it over to Dr. McCabe.
Hello, everybody. Thank you for joining us. There's been a lot of information in the media, and I'm delighted to be here to start to sort through fact versus fiction and walk you through some of the steps that we here at Teladoc Health, as well as InTouch, are doing to be supportive of our healthcare system and our public health system. So this first map is done by Johns Hopkins. This has been an incredible movement forward since our last pandemic in 2009 with H1N1, where we're starting to see the uptick in spread of the virus across the globe. We've learned a lot since 2009 from H1N1. What makes this something that people are very concerned about and watching is it's a new virus. And we don't yet know a lot of information that will really settle over time in terms of how contagious it is, how easily it is to spread, as well as mortality rate. So things like this, like mapping out to see where folks are getting identified and how it's traveling the globe, are very important. Teladoc Health is a global company. We've got medical directors in all of the various locations across the globe: Canada, Shanghai, China, Australia, Europe. And we're meeting regularly to kind of look and see how the virus is spreading. We get a lot of questions around epidemic versus pandemic. Epidemic is usually more of a regionalized location of a spread of a contagion, and it's at higher levels than one would expect normally. You move into the pandemic range when you start to see that jump continents and go into other countries. And we're certainly starting to see that, even though the World Health Organization hasn't necessarily declared that. Just let me see if I can't, there we go. One thing that's important to discuss is, just putting it into context. We're certainly concerned and cautious about COVID-19 and giving it its all due respect, and making sure that we're being very aggressive on the start, because we need to give ourselves time to learn how this virus is going to behave. And Dr. Siddiqui will talk a little bit more about that. But you can kind of get a sense from, we're in flu season now. So just to, as a public health physician, it's very important for me to remind you, make sure you go get your flu shot. Even if you haven't gotten it, it's still a good time to get one. Flu is out and about. Estimation, not everybody goes to their healthcare provider to take care of flu if they get it. So, a lot of the modeling that is used to look at how many people are actually coming down with the flu across the US really take into account how many are showing up in the hospitals and their doctor's offices and testing positive for flu. And so estimates are based on that, upwards of 30 plus million people are going to have the flu this season, and estimates of death due to flu, 18,000. It's important to kind of put that into perspective, because I think we're so used to the flu that we kind of almost put it on the back burner. Now, COVID-19 is new. Its rate of infection, transmission is a little bit higher than what we typically see for influenza. And the mortality rate, that's still coming in, but it's looking, compared to a typical flu season, a little bit higher. A typical flu season, you're probably going to have 1/10 of 1%, 0.1% mortality rate. And COVID-19, it's looking between 2 and 3%. But again, those numbers that we saw from the Johns Hopkins website and the World Health Organization website, you're seeing about 93,000 plus cases at least identified today. It's still in the small numbers. Even as we see testing come on board in the US and we start to see numbers go up because of testing, it's still a relatively small number, and you'll see containment strategies still in play. But important to kind of keep that into perspective. And if you didn't hear me the first time and you didn't get your flu shot and you're able to, go get your flu shot. It protects you and it protects all the folks that you care about, including those folks who are more at risk for complications of flu and as you'll learn, COVID-19. So those folks that have other chronic conditions such as asthma or heart disease or diabetes. I did want to spend a little bit of time talking about, at least with regard to how virtual care is playing a role in this outbreak, epidemic, moving into pandemic. Something like virtual care is really critical because it helps reserve those high acuity facilities that are going to be taking care of the folks that come down with COVID-19 that end up having more severe complications. So having folks be able to call and not go into a facility to kind of deal with the more mild symptoms, to go through the triage and screening to determine should they get tested. And we'll talk a little bit more about the kind of protocols in place. It really helps reduce the spread if you can actually keep people in the home and keep them distanced and not congregating in places where you're more likely to pick up the virus. It also protects our very valuable healthcare workers. They're going to be on the front lines. They're the ones at very high risk because they're on the front lines seeing folks come in. So if we can manage folks who have mild disease or have questions or concerns remotely, that leaves the ability of those healthcare workers to see folks at higher acuity level and basically be better able to protect themselves and reduce the spread. The strategy right now is really trying to continue with containment, even though we're seeing more and more people come test positive. The critical piece is if you can isolate and spread folks that are high risk, confirmed positive, and reduce the spread or the trajectory of the virus. That buys time, and it also slows the spread and is very important. So virtual care has a very distinct role. The other component of this, which I think is going to be very interesting and exciting, is with the virtual care networks and the ability to leverage data at very near real time, is being part of the public health effort for surveillance and being able to give those local, state, and federal authorities a little more information sooner to start to make those difficult decisions around what are called non-pharmaceutical interventions, which can move into deciding to close schools, deciding to stop events, deciding to recommend that local employers have people work from home. There will be different strategies deployed for various areas depending on the burden of the virus. And those are obviously, as you can imagine, if you're an employer, very difficult decisions. When do you make that call? And having more information to be able to do that, like you're seeing an uptick like you would for flu, can help make those decisions sooner rather than later, and then reduce the spread. So I did talk a little bit about this. This is one of the things that we've been working on, making sure that, both globally, we have medical directors around the country. We huddle, depending on the response time, we started huddling very rapidly, then weekly, and now we're back up to huddling a little bit more rapidly. But working and coordinating with the public health system, that includes the working with the World Health Organization, the CDC, state and local entities. Our role is really important in making sure that we collaborate with the local health authorities, so that as we identify through our screening, through our persons under investigation criteria screening, that we are able to communicate with those local health authorities, who can then do contact tracing, and start to determine, who needs to be in isolation, who needs to stay home, how long do they need to stay home for, and be able to deploy those public health measures. Again, without having a pharmaceutical intervention at this stage, and without having a preventable vaccine that prevents the virus for people contracting the virus, it's really important that we employ those non-pharmaceutical interventions. So we are in touch with the CDC as well as the World Health Organization, and starting to move into being part of the surveillance network to support data going to the right people to make good decisions for the folks and the communities. So what if we, at least from the US-based perspective, I'll talk a little bit about what we're moving into now. As with any novel virus, you get people on the ground and you try and understand what are the clinical signs of this virus? How would we be able to detect early that somebody might have it? You then have to develop a test to confirm whether or not the person has it. Our role in this is to make sure that as people come down with mild symptoms that often appear very much like an upper respiratory infection, that we go through the necessary kind of high risk characteristics, screen for those. For example, travel history. We knew that this started in certain parts of China. It's since spread. So being able to quickly identify, which of the folks that are calling in with cold symptoms might actually be at higher risk for having COVID-19, based on travel history, based on contact history. This type of criteria does shift as we learn more about the virus, and we'll start to see this definition shift as we go from sporadic cases here and there to a little bit more community spread. But it's really important that we arm our physicians, the folks that are on the front lines, to be able to have the tools necessary to be able to screen. Once we screen, it then becomes important to get that person connected into the public health system. Now, when we say connected into the public health system, it doesn't mean we send them anywhere, but because again, if somebody has mild symptoms, we want to manage them at home. And we also want to give good instructions about how you manage somebody at home and prevent the spread among other people in the home. We connect them up with local public health. It is there right now in current state that they're going to help determine testing to determine if they are a confirmed case or not. We don't test. Pretty much the only entities right now are the public health entities that have the test kits. And so our role is just guiding home care and being able to support the connection into the public health system, and then basically being able to support that patient with home care and necessary guidance on keeping the rest of the family safe and trying to reduce spread to other family members. If it hasn't been said enough, I think the most important things that people need to be doing right now, this helps limit the spread. It's great because it works for any virus, flu or COVID, and they sound simple, but they're so critical to being able to prevent community spread. Hand hygiene, wash your hands. If you can't get to wash your hands, use hand sanitizer. Try and get around to wash your hands, because washing your hands and using hand sanitizer are ideal. Cough etiquette, cough into your elbow. If you have to cough into your hand, use a tissue. Throw the tissue away, make sure you wash your hands, use the alcohol-based hand sanitizers. Refrain from handshakes. Do elbow bumps instead. Avoid close contact with people who are suffering from colds or acute respiratory infectious type symptoms. Stay home when you're sick, and avoid unprotected contact with farm or wild animals. Clean and disinfect frequently. I think what's important is all along, even with COVID, these are common types of messages that we want to get out to our members and our clients and their health plan members or their employees. This is a window of opportunity to continue to hone those messages, because it's both important for the flu, as we saw, and for the coronavirus. And finally, on a word, I know there's been lots of discussion and talk, and I'm sure Dr. Siddiqui will talk a little bit more about this, but, we're learning a lot about the virus, how it behaves. If somebody gets it, what are they likely, what's the clinical course likely to be? If you have a mild clinical course versus somebody who has a severe clinical course, what are the other medical components of somebody's medical history might make somebody more at risk for severe disease. Those are all starting to come to light, and more will come as we learn about the virus. The other component is where, can you pick this virus up by touching surfaces? And like other coronaviruses, and a coronavirus is part of the common cold family of viruses. It does live on inanimate surfaces. But the good news is, and you can see the article right here, they've gone through and they've looked at various effective measures for, environmental controls, which are a very important component of any kind of intervention that you're going to be doing to reduce spread. And you can kind of see there that the traditional ethanol concentration, 60 to 71%, 0.5% hydrogen peroxide, 0.1% bleach solution, sitting on surfaces for 1 minute are very effective. Part of, as employers, you're going to see the emergency preparedness plans have been rolled out. Everybody's contacting their critical vendors to see how they're going to mitigate any disruptions in service. And these are things you're thinking about as you're starting to plan for the safety of your workforce or your health plan members. Essentially making sure that the folks that clean your facilities are on board and know how to effectively clean various places. And then, as we, can't say enough, important to wash your hands, cover your cough, stay home when you're sick, and leverage the ability to use remote type services, particularly if you are not in active distress or clinically quite unwell, it's important to use those virtual services because it will reduce the spread. It also will reduce the chances of you picking something up if you head to in-person urgent care or primary care, your primary care doctor's office.
Thank you, Dr. McCabe. This is Javed Siddiqui. I want to, first of all, thank InTouch Health and Teledoc for the tremendous opportunity to present on this important topic today. As Dr. McCabe gave you the epidemiological background and information, I'd like to focus more on what we know so far with regards to the clinical presentation. Obviously, there's been a great deal of information, and the information that we're getting is expanding rapidly. But I also want to put forth a very important caveat. Our understanding of what is going on is changing literally on a daily basis. So please, this is the most up-to-date information that we have, but again, as the clinical scenarios evolve, we'll be expanding and updating the information. So from a clinical epidemiology standpoint, SARS coronavirus 2, which is the virus associated with COVID-19, right now the incubation period is about approximately 5 days with an interval of 4 to 7 days. In addition, multiple studies have looked at the range of incubation. And when you're looking at data from human infections with other types of coronaviruses, because recall that SARS coronavirus, the original one in 2002, followed by MERS, they had a suggested incubation period of 2 to 14 days. One of the other things I've tried my best to include all the pertinent references in the slides as well. So you know exactly where the data is coming from. So the next slides on the clinical presentation are a summary from these 3 papers published in both the New England Journal of Medicine, the Lancet, and again want to acknowledge that our information is evolving, but the most frequently reported symptoms of COVID-19 include fever, cough, myalgias, fatigue, shortness of breath. And yes, those are fairly non-specific symptomatology. Yes, those are symptomatology of the classic influenza-like illness, but in the context of what we're facing today, again, if you have fever and definitely shortness of breath, this is a clear indication that you know, the patient may have been exposed or the patient may have COVID-19, and I think these are important epidemiological signs and symptoms that we need to be aware of. This is the data with regards from the cases in Wuhan. When you look at the age distribution and the death rate, obviously those 60 years and older are at the highest risk, with obviously 80 plus accounting for 14.8% of the death rate. One of the things that has been discussed quite a bit, and several hypotheses, but no clear-cut data, but ages 0 to 9, there were no fatalities reported at the time of this publication from Wuhan. With regards to pre-existing medical condition, cardiovascular disease remained the highest at 10.5 mortality rate, diabetes, chronic respiratory disease, hypertension, and cancer. No pre-existing medical condition, the mortality rate was at 0.9%, as you can see. So let's look at the clinical timeline with regards to this. One of the aspects of COVID-19 that is definitely of concern, and part of the case report also presented in the New England Journal of Medicine, was the fact of asymptomatic viral shedding. Now, this is an incredibly important aspect of this disease, meaning that the patient is asymptomatic, they haven't yet developed that fever, cough, myalgia, shortness of breath, but they are actively shedding the virus. And again, the measures that Dr. McCabe spoke about, washing your hands, again, it is amazing how in the field of infectious diseases we come back to the importance of washing hands, and something that we continue to stress, as well as good cough etiquette. But we need to be aware of the asymptomatic shedding. When we're getting to day 1 of the illness, obviously a patient develops a fever, again may experience fatigue, myalgias, dry cough. Only a minority of patients so far have demonstrated diarrhea or nausea within the first 2 days. By day 5, patients may have difficulty breathing, and this is definitely, we tend to see a higher incidence of this in older age, as well as patients with pre-existing medical conditions. Now, the most severe clinical situation that we're concerned about is the patients developing acute respiratory distress syndrome, otherwise known as ARDS. One of the unique aspects of COVID-19 is the fact it uses an angiotensin converting enzyme 2 receptor, or ACE2 receptor, within the alveolus. And we feel this may be part of the pathophysiology of the disease, leading to a pneumonia and obviously leading to acute respiratory distress syndrome. Majority of the time, I've seen this around day 8 with the onset of it. And those patients who are recovering, patients usually are discharged from the hospital around day 17. So the best data we have, this is the clinical timeline. Obviously, there's going to be, as the wealth of data increases and the number of cases that we have data on increases, this is going to be changing a little bit, but this is where we are as of today. So Telemed to you, we've been very fortunate to be involved in COVID-19 and taking care of patients who are actively ill with this illness. We have, our group has been very privileged to take care of 3 patients from the Diamond Princess cruise ship who are repatriated to the United States. We've also been involved in a number of cases designated as patients under investigation. We have seen and helped manage these patients all through telemedicine, using InTouch health devices, and helped develop a workflow that works best for this. And obviously, infection prevention is a key portion of this. So with that said, I want to spend a little bit of time discussing the infection prevention issues, and that really relates to device cleaning, because obviously the device is within the patient room. And one of the things I really want to acknowledge is what a tremendous job telehealth and the CDC has done to acknowledge telehealth and the role of telehealth in this outbreak. I was going to say pandemic, but obviously we don't want to use that word until the World Health Organization, the CDC, are officially labeling it as such. So with regards to this outbreak, telehealth, I think, continues to play a very vital role. And I think telehealth's role in dealing with COVID-19 is really 2 different aspects of it. One is being able to bring the right expertise to evaluate the patient. So true, patients or clinics and hospitals that may not have access to infectious disease specialists or critical care specialists or specialists who are familiar with how to manage patients with COVID-19, telemedicine allows you to bring that expertise to your clinical facility. In addition, telehealth also plays a very important role in workforce multiplication. From the Telemed to You side, we are able to cover numerous hospitals, provide our expertise to them through telehealth technologies, and really be able to provide that seeing the patients, following them on a regular basis. And I've said over and over again, by having InTouch health devices at my hospitals allows us to be able to see patients even more frequently than I would in an absolute bricks and mortar environment. So with that said, cleaning of the device is incredibly important because, again, these devices are right at the patient bedside, right? We are seeing these patients. These patients are coughing. There's exposure of droplet nuclei onto the device. So cleaning the device is an important aspect of it, right? So couple of the things when we're talking about cleaning the device, we don't want to attempt to open or remove any part of the device. Obviously, we don't want to remove any covers because we want to reduce the risk of any type of electrical shock. Obviously, want to refer servicing or repair of the devices to qualified personnel. Now, when we're cleaning these devices, again, the personnel that are going to be in the room are going to be using personal protective equipment, right? They're going to be having gloves on, gowns, face shields, masks. So with those gloves, right, the idea is with that personal protective equipment, excuse me, the idea is the unit is to be cleaned within the room before we exit the room. So we need to make sure that we have those cleaning materials available so we can clean the unit before it leaves the patient's room. From a cleaning instruction standpoint, there's guidance from the CDC. The link here on the presentation will help you deal with that, not only with regards to COVID-19, but with regard, obviously, other respiratory pathogens and other pathogens that we use telehealth with. So what do you need? Obviously, disposable gloves and appropriate cleaning agents, and then disinfectants. And again, Dr. McCabe referred to the paper in the Journal of Hospital Infection by Kempf and colleagues. Again, hyperlinked here on this slide. Really appreciate the fact the Journal of Hospital Infection has made this paper available online. So would I recommend that if you have further interest in this topic, to please refer to that paper. Again, what are some of the disinfectants that we can use? Oxide, ethyl alcohol, isopropyl alcohol, but again, we want to make sure we're doing 62 to 71% ethanol from a COVID-19 standpoint. The sodium hypochlorite, again, these are all types of agents that we can use from a cleaning standpoint. Right. So we'd like to show you a video of cleaning the equipment. There's no audio associated with this video. I want to just talk over a few things. Obviously, unplug the device. That's critically important to prevent any sort of electrical issues. And in cleaning the device, we want you to take your time. Right, time is of the essence. We want to make sure that we're cleaning the surface. Again, the concept is that the patient has coughed. There's droplet nuclei on the device. We want to wipe away that droplet nuclei before the unit moves into another room. Right. There you see, with regards to the cleaning mode, gives a 30-second countdown. It gives you an opportunity to know that you're spending the appropriate amount of time wiping down the surfaces. We want to be cautious not to damage the sensitive portions of the equipment. Previously, we were seeing the camera. I want to make sure we don't damage the camera. We want to disinfect the surfaces according to your hospital policy. And then the key thing is letting time to dry, because here we've wiped down the equipment with the appropriate agent, but we still need to give it time to dry. And then obviously, once it's back in its home area, plug the device in. So that was a quick review of how to clean the device, some of the clinical epidemiology of it. I'll turn it back over to Scott.
And so with this, now we'd like to move on to the question and answer portion of the webinar. So please make sure you get your questions through at the Q&A widget. First one is for our two presenters is, what is your recommendation if the provider suggests the patient get tested for flu or COVID-19? Do you notify the facility or public health, or both?
Dr. McCabe?
Yeah, so and I think one of the things that Dr. Siddiqui had said is a lot of this will change over time, but the current way right now is with testing being done through your local public health departments. First and foremost, when somebody calls virtually, a physician is going to go through kind of the standard questions, past medical history, medications, any additional illnesses, chronic diseases, quickly trying to ascertain, is this patient appropriate for virtual care services, right? So I think one of the key pieces is most people will have mild disease, but if there's any sense that that person is having respiratory distress, trouble breathing, they need to be seen in person. Virtual care really is not the right avenue, at least from the initial stage. And I'll preface that by saying, when you're in the hospital and having a virtual specialist come, that's very different. But when you're coming in the front door of like your first visit and you're having questions, that's really critical. We've got to determine, do you need to be seen in person? When that happens, what's really critical is this is a reportable disease across all states. So we are required to report if that person screens for persons under investigation. What that does is that kicks off a process over at the local public health department. And they were going to basically, through their epidemiologic nurses or other epidemiologic trained staff, either remotely or in person, go and reach out to that suspected case. They're doing that because they've got to quickly do contact tracing, figure out where that person's been. They're going to take into all of the clinical information that Dr. Siddiqui provided in terms of how far back they're going to look and see where that person traveled, who that person came in contact, because they have to assess all those contacts, the risks that they would have, and make a plan for either at-home monitoring or isolation. They determine testing at that point. So it's not sending somebody out to a local lab. You don't want to do that. You know, particularly for somebody who can be managed at home, you want them to stay managed at home. And then you also want them to do things in the home that help prevent the spread for people that live in the home. And so we have great guidance, at least, you know, in the United States, as, you know, we follow the CDC, and globally the World Health Organization. Great patient information that is shared and explained with the patient while they await the public health group and the testing to be done. You know, they're starting to send out testing kits, and Dr. Siddiqui can kind of speak about this, being more on the front lines. But, you know, in terms of the turnaround time to test, you know, between getting a positive or a negative, and then really understanding what is called the sensitivity and specificity of the test, like positive predictive value. Are you able to identify all positive people? Are there any false positives, any false negatives? It takes a little bit of time for that to turn around. So what does the person do in the interim? And we provide guidance there. If we do have to suggest somebody gets seen in person, we did this with measles. Let them know before you go. Or if we have to invoke a 911 protocol, let the ambulance EMS services know, let the facility that the person's going to know, because we want it to be a controlled transfer. What that means is we want the facility to know if somebody's coming in. They might bring them in a different doorway. They might shuttle them in a different, put them in a room right away. And we want to give them every option to be able to do that, so they can basically start to use their infectious control procedures to really minimize the spread to other patients and to their own healthcare workers. So right at this stage, it's really syncing up, again, using virtual wherever we can. You'll see your public health departments using virtual, calling in and doing a lot of assessment if they have to be on the ground, you know, working with their public health nurses to make sure they're safe and collecting specimens. But if you can keep people at home, not spreading and walking around the community, that greatly will reduce the chances of it spreading.
Dr. McCabe, if I may add, one of the things that we're doing in the hospitals is obviously ruling out the patients for other types of pathogens before thinking about sending a nasopharyngeal swab to the health department, because obviously right now there's a little bit of a choke point with regards to testing. So we've been using the multiplex PCR systems such as BioFire. So when the patient comes in with the symptoms described, fever, respiratory tract infection, we've been doing the multiplex PCR such as BioFire, and then making sure that we're not diagnosing them with another type of common respiratory condition. If that's been ruled out, then evaluating them for COVID-19 testing.
Thank you both. So our next question is, do we know the sensitivity and particularly the specificity of the COVID-19 test, and how long does it take to get results from the testing?
So, you know, Dr. Siddiqui is probably more on the front lines with that. There really hasn't been a lot of information published on that yet. And I think that's pieces of information that everybody is really waiting to hear from. Dr. Siddiqui, do you have a sense of what you've seen from the folks that have tested in your area?
You know, one of the things is that obviously the public health department is doing the best job possible with regards to COVID-19 testing. Again, what's happening in in California is that we obtained the nasopharyngeal sample. That sample is then sent to our local public health department, who will then work it to the various public labs for testing. And then I believe the CDC is still doing the confirmatory test, and then that information is coming back. We've had varying degrees of timelines, anywhere from 3 to 5 days. It's been our our experience, but I know they're working incredibly hard and doing the best they can. I'm sorry, I actually don't have, and I have not seen any numbers specifically related to the published sensitivity and specificity of COVID-19 testing. I know as we expand testing, and I think as it is a PCR-based test, so I think that we will get that type of data, but I have not seen any published sensitivity and specificity data.
Thank you, Dr. Siddiqui. So then kind of related to that, I guess not necessarily on the test itself, but more on your screening process, are there any travel locations that you're using, or what's your specific Telemed2U's location and just screening questions? And are your physicians calling the health department directly? What's your process with that?
So oh, I'm sorry, please, Dr. McCabe, please.
Oh, okay. So yeah, that we're constantly monitoring, particularly in the U.S., the travel advisories that are being set up through the CDC. So again, following a lot of the information that they have with regard to travel history. So yes, we follow that. That gets updated. As they look at that, that gets updated quite frequently. So we have put in the workflow particular screening tools for our physicians to leverage, which will help them as the PUI criteria changes to then be able to ascertain, basically low, high risk. We support the physicians with the report out to the public health department. We are expanding a 24/7 nurse line that we have to help facilitate the linkage to the public health system. This was the same kind of response team that was stood up globally for Ebola. And so leveraging a lot of that learned experience for being able to kind of link into as we go from a situation that's rapidly changing, as we go to try and link patients who may need either connection into the public health system or connection into their local facilities to be able to facilitate that for our physicians.
And to give the Telemed2U experience, again, we've been in touch through our hospitals and directly with the public health department. We're not calling them on every single case. We've developed a nice protocol with regards to that throughout the state of California. So again, the workflow or the algorithm that we've been working is that obviously asking anyone if there's been any travel or contact with people who have traveled. Obviously, the CDC website contains the level 1, level 2, and level 3 countries, and that is changing, so definitely keep an eye on that. And then based on that, their symptomatology, again, moving forward with the multiplex PCR, such as BioFire as the first option. I know Veregene is another available option for patients as well. Doing that type of multiplex PCR, if that is negative, and we feel that the patient is someone who should be tested, we'll then obtain the sample and send it to our public health department. Obviously, there's been a great deal of discussion regarding community transmission. I think that testing, wide-scale increasing availability of testing will definitely help deal with that. But at this point in time, that's the workflow that we have adapted, and we will change as the information and availability of testing changes.
I think that's a really important point, that we're really trying to develop systems and communication methods and putting things in workflow so that people can adjust smoothly to the next phase of that we're going to see when we start to see, a little more community spread, hotspots, et cetera. It's really important to be able to get that information out to the folks on the front lines that are going to be fielding the patient inquiries or the consults, to be able to give them as many tools as we can, but being able to not overwhelm them with alert fatigue and communications, but just the right information at just the right time, and try and make it easy to do right and hard to do wrong. and make sure that we give appropriate guidance that's easy to follow and link as best we can to the, it's a system at play here, to link as best we can to the public health system and the facilities that will be taking care of the more higher acuity cases. So I think the important point, just as Dr. Siddiqui said, is we're continually trying to improve this process and make it better, and continually listening to the folks that are on the ground, on the front lines. How do we do this better?
Thank you, Dr. McCabe. So in that same point of workflows and process, I was wondering if there's a process in place for monitoring patients with confirmed COVID-19, I guess both in isolation and after they get discharged.
I can speak from the hospital standpoint that obviously with those patients that we've taken care of with confirmed COVID-19, obviously we had them in isolation at the hospital. Again, we were sending samples to the public health department, nasopharyngeal samples. We're also involved in the study to look at viral shedding. So these patients were getting nasopharyngeal swabs on a daily basis. But again, want to make sure that everyone understands that was part of a study to understand viral shedding. And as far as discharging the patient, that was when we felt clinically the patients were stable. That was a conversation to be had with the public health department and CDC, and only when when we all agreed the patient was stable for discharge, those patients were able to be discharged. Again, most of those patients did not return home. The 3 patients that we took care of from the Diamond Princess then went to quarantine centers to remain in quarantine. I think that as the outbreak continues, I think patients being able to be at home, quarantine at home, is going to be incredibly important. And then there again, I think that telehealth and telemedicine technologies play an important role to be connecting with those patients at home. So I can very much envision where the patient is discharged from the hospital, but that post-hospital discharge, the patient goes home, remains quarantined at home for a specific period of time. And while they're at home, we're using telemedicine and telehealth technologies to touch base with them on a daily basis, to check in with them, see how they're doing. And again, showing the role of telemedicine and telehealth in this outbreak. Dr. McCabe?
Yeah, exactly. Once they're, somebody who is screened for particularly high risk and move into getting testing and test positive, then it becomes, the public health authority, the local and state, things are done at the state level, where they're going to make a determination what they want that patient to do and give instructions. And so they have the actual legal authority to put somebody in quarantine versus recommendations for home isolation, at home monitoring. And so the real key is we've talked a lot about this, is making sure that we're doing the pass-offs and that we're communicating clearly on those pass-offs for what people have to do. So, for example, if you test positive for COVID, the public health department really has to, ascertain what is the risk to the contacts, determine what kind of isolation measure, quarantine measure they're going to do and how long they're going to be there. And Dr. Siddiqui mentioned that, that's what they're doing when they're in the hospital. If you've got a positive patient, when is it safe to move them into the next phase of their care? Where are they going to go? How is it going to be done? And that's a constant collaboration. And I think, as we mentioned before, really important to make certain that folks understand this does change rapidly. And I think a real key piece to all of this is, the digital interconnectedness that we now have allows us to be able to make changes a little bit more easily and more quickly to be able to adapt to the rapidly changing situation.
Thank you. So this next question is, are your patients getting calls back from the health department, and is there a time frame if they are?
Our patients are actively being followed by the public health department. I don't know exactly what the interval of those phone calls are, but the public health department is really doing an outstanding job with regards to communicating with patients, working with the hospital, and working with us as infectious disease physicians. So they've been really wonderful to work with, and really applaud them for all their hard work.
Yeah, and one of the things for people to realize is since 9/11, with the preparedness dollars that came down from the federal government to the states, the enhanced ability to be able to stand up these call centers, which they leveraged both in, they had some significant tornadoes just in Nashville, Tennessee, or this pandemic situation. They're able to bring together the right folks, the fire department, the EMS, the hospital systems, the government, to be able to make quick decisions and understand how things are working. They use that same technology now when they're actually deploying the public health workforce to determine, is this person low risk or high risk? Well, what do we do with them? In terms of testing, in terms of what do we do in the interim while the test is being waited, we're waiting for the test results. What do we say to the patient? What do we say to the family? Again, as we do a pass off, like, virtual care from the Teladoc Health perspective is kind of the first door into kind of an urgent care, primary care appointment. You've got some symptoms and you're not critically ill, and you want to do it virtually, which is again, a great way to prevent spread. We've got to make sure that we give clear instructions to the patient when we make a transfer over. And when I say transfer, we transfer information about that patient and report the patient to the public health department, that we tell them they might not get back to you right away because you might be lower risk than some of the other folks are dealing with. But in the meantime, while you're still having the sniffles, it's best for you to stay home. Based on my screening, you're tending to have a little bit more of the risk factors that would say, we suggest you stay home and do at-home care, and also guidance on how to keep others in the home from, getting the virus as well, the things you can do to mitigate those risks. Again, very important. And I think the public health department is triaging any reports that come in, and they're going after the ones that are really high risk, and they're trying to really gather as much information to kind of bring all of the potential high risk contacts of that index case, so that they can, again, slow the spread of the virus.
Thank you, Dr. McCabe. So we're getting towards the top of the hour, but we still got time for a few more questions. Early in the presentation, there was a warning about contact with farm animals. And this question is related to maybe people who live in these large rural states where there might be farms or ranches with animals. What are the issues related to patients in those settings, and is protection needed if they do interact with animals?
So I'm going to say that those are kind of general guidelines. I would say the risk here is exceedingly low, particularly since we just really have a couple hot spots right now. I think in general, the guidance is that, if you're sick, in terms of being in contact with animals, or an animal is sick, you being in contact with them, is best to have space and not have that. So just to reiterate, the risk really is quite low. That's kind of general guidance. And as with anything, if your pet is sick, obviously vets have ability to kind of triage on the phone. It's best to kind of again, good hand hygiene, good keeping, if someone's sick in the house, kind of keeping them in their own room and trying to prevent, as you would any other kind of viral illness, trying to prevent other folks from your house all coming down with it. Again, very standard kind of guidance. Again, risk is very low for the United States. Obviously, this, and Dr. Siddiqui can talk a little bit about, there's a cycle of how these viruses, they move through different hosts, and that's where they tend to change. So this coronavirus could have, in terms of, as they start to look at the history of this virus, it starts out as a virus we've seen before. It goes into an animal host. It might go into another animal host, and then it can then potentially go into a person, and it's when the person gets it, and then you start to see person-to-person transmission. And so, for all intents and purposes, it potentially started as some sniffles in bats. Bats came in contact with animals that were sold at the market in China, and that transferred over to a person, and then there was person-to-person contact, and now we have a new virus. And Dr. Siddiqui, being an infectious disease specialist, can talk a little bit about that as well.
Thank you, Dr. McCabe. the publications in Science which sequenced the virus found that there was, I believe, an 88.7% homologous to the coronavirus found in bats. So as Dr. McCabe was very appropriately saying, the zoonotic aspect of this is incredibly important with these types of viruses.
Thank you, Dr. Siddiqui. So we have time for one last question, and that one is for those patients that you have in isolation at home, are you having them monitor themselves, or are you using the CDC self-monitoring log, or how is that happening?
Dr. McCabe?
Yeah, so again, it's level of risk. So if they're very low, if they're no risk, and this is going to change. But with regard to hotspots in communities, it depends where the patient is. If you have community spread or you're starting to see community spread, the risk goes up a little bit. But if you don't have community spread, right, and most of the places across the U.S., the vast majority do not have community spread, the chances of you having COVID are very low. And so basically it's general guidance. We do link to the public health system to make sure that we're working with their epidemiologists to kind of determine risk. But for basically no risk and low risk, the guidance is self-home care, particularly, and it depends if the person's calling it with either asymptomatic or symptomatic. And the general guidance right now is if you're asymptomatic and you're basically low risk or no risk, is kind of general care. And then if you are symptomatic, you should be staying home. You should be getting better. Even if it's probably another viral illness, and if it could be flu or something else, you don't need to be passing it on to your colleagues. And so the general guidance following along flu parameters is, stay home until you're at least 24 hours afebrile.
Thank you so much. So again, for the questions we weren't able to get to, we will have a follow-up afterwards. So now this concludes our webinar, and I have to give a big thank you to our two presenters. I'll also like to let everyone know on the call that we will be following up with having these slides be available, a recording of the webinar, some extra device cleaning guidelines, and that device cleaning video will also be available to everyone, as well as more information on our tele-isolation solution. So thank you so much, everybody, and have a great day.